So welcome to our webinar today, entitled Hospital and Healthcare System Decarbonization, Improving Public Health. Before we begin, all of us at Medical Society Consortium on Climate and Health respectfully acknowledge that our advocacy, education, and learning across the country takes place on occupied and unceded lands of many Native American tribes. To acknowledge this land is to recognize its long history and our place in that history. It's to recognize these lands and waters and their significance for the peoples who live and continue to live in this country, and whose practices and spiritualities were, are, and shall always be tied to the land and the water. Today's webinar is the first in our 2023 Climate Justice webinar series as part of the Climate and Health Equity Fellowship Program. The CHEF Fellowship Program, as we call it, is a program that recognizes the need for more diversity in climate and health leadership and a sharper focus on equitable climate solutions. The goal of the fellowship is to empower doctors of color from populations that face greater burdens from climate effects and are underrepresented in medicine to become leaders in the climate and health equity education, advocacy, and policy solutions. I'm Dr. Mark Mitchell, the founder and director of the Climate and Health Equity Fellowship Program. Also joining me from the consortium to run this webinar are program manager Jordan Curry-Carter and our digital communications and multimedia program assistant Clarissa Payton. They will be available throughout our presentation through the chat in order to answer any technical questions during the webinar. Our other team members on the webinar are Dr. Venice Curry, Dr. Kimberly Williams, and the webinar is hosted by the Medical Society Consortium on Climate and Health, and is held for 1 hour on the second Friday of each month from 3 p.m. to 4 p.m. Eastern. Today's webinar will be recorded and made available on our website for future viewing as part of the Equity Resources page of the consortium website. This year, we're pleased to offer CME credits for our webinars for physicians. Instructions on obtaining credits will be provided at the end of the webinar and on our website for those of you who are looking at our recording. Today, we are honored to have one of our own, Dr. Shaneeta Johnson, program manager of the General Surgery Residency Program at Morehouse School of Medicine and Grady Hospital, and also Deputy Director of our Climate and Health Fellowship CHEF program. We also have Dr. Neelu Tummala, otolaryngologist, surgeon, and co-director of the Climate Health Institute at George Washington University. A description of their impressive work can be found in their bios, which are now being dropped in the chat. As healthcare providers, it's important to consider the role that healthcare systems and providers play regarding climate and health. In this webinar, Dr. Shaneeta Johnson and Dr. Neelu Tummala will discuss greenhouse gas emissions of public health systems and the impact of these emissions have on public health. In addition, the speakers will present equitable solutions that health professionals can take to address these impacts. The general format for today's webinar will be 20-minute presentation by each of our speakers, followed by 10 minutes of questions and answers from our audience. We ask that you put your comments, links to any resources that you may have, and any questions that you have for our presenters into the chat box at any time during our presentation. We'll get to as many of the questions as we can during the question and answer period. Please keep yourself muted so we're not interrupted by background noise. Shaneeta, you may go ahead and begin.
Thank you very much, Dr. Mitchell. I'm going to go ahead and share my slides here. It is a pleasure to be able to speak today on an important topic, healthcare decarbonization. I have no relevant disclosures for this talk. So we know we're here to talk about climate change and its impact on health, and specifically to talk about the health system. So we know the exposure pathways that are here in the center of this slide: extreme weather events, heat stress, air quality, water quality, etc. But I like that that this slide shows the vulnerability factors and the health system factors that modulate these exposure pathways. And so where we live is important, and who we are is important. What are our demographics? What are our socioeconomic factors, socio-political factors? What's our health status at the start? And then what about the health system? Is the health system in a place that it can help to improve these risk factors, or will it worsen it because we don't have access to care as we need it? And at the bottom of this slide shows our health risks, and this is why we're here, because climate change impacts our health and the health of our patients and communities. And so injury, mortality, vector diseases, etc. There's so many risks that we know are caused by climate change. And then on the side, it talks about the health systems and the facilities outcomes. And so the impact climate change is having on our healthcare facilities and their ability to take care of our patients and communities. And then we're going to talk today on the impact that the healthcare system is having on climate change. So we are all impacted by climate change, but we also know that there are some folks that are more impacted. So the elderly are more vulnerable to extreme events, to heat, etc. Low-income communities do not have the resources sometimes to relocate, to remove themselves from danger, from extreme weather events, from flooding, from heat. Our kids have high risk of heat stroke and heat illnesses. And then communities of color or disadvantaged communities may be exposed to higher levels of pollutants, etc. And so this slide from the EPA really shows how the climate impacts us all, but it's modulated by the environmental and institutional context in which we live and our social and behavioral context. So the geography of where we are, the agricultural production where we are, the age, gender, race, ethnicity, poverty levels all play an impact. And then at the bottom of this section, our access to care and our pre-existing health conditions. These all modulate the exposure that we are exposed to, and then the health outcomes that come about. So climate change has an impact on healthcare. We know that the increasing temperature, increasing natural disasters, rising sea levels, and air pollution do have an impact on our health. So particularly for surgery, we know that it has an impact on the frailty of our patients as they come to see us prior to surgery. So we have increased cardiovascular disease, increased respiratory disease. That impacts how well they are able to weather the impact of surgery itself. Then we're also aware of adverse birth outcomes and the increase in preterm births. There were 2.7 million air pollution associated preterm births in 2010 alone. And then there's the increased trauma burden from extreme weather events that increases the risk of injury and mortality. And then we have relocation of our communities from these disasters and the increasing temperatures, but we also have relocation of the health services, which impacts access to care for our communities. And then we may also damage the infrastructure from the from the extreme natural disasters and extreme weather, or overburden that infrastructure, which means that we don't have enough capacity to take care of folks. So climate change is increasingly impacting our health, but it's also increasingly impacting the ability of our healthcare system to be effective in its response to these events. This is a large portion of our economy. It accounts for almost 20%, almost 1/5 of the US GDP. But it also has a large impact on climate change. So when we talk about greenhouse gas emissions, the US health sector is responsible for about 8.5% of US greenhouse gas emissions. Globally, the healthcare sector is about 4% of the greenhouse gas emissions. When we look at this diagram to the left here, we can see that the top 10 countries are listed here with their global healthcare footprint. And the United States is number one at 27% of the global health sector emissions. It has the highest healthcare emissions per capita. We are followed by China and the European Union. And it's also significant as far as its financial impact, with more than $600 million in direct health costs and more than $5 billion in indirect costs. From 2010 to 2018, our greenhouse gas emissions rose by 6%. On the left axis, you can see healthcare-related GHG emissions for the nation, and on the right, they are per capita. Obviously here, you can see that most of our emissions are related to scope 3, with scope 1 being our smallest, scope 2 being the middle, and scope 3 the most. So scope 1 are direct emissions from healthcare facilities, scope 2 emissions from direct purchases of energy, and scope 3 supply chain emissions. But there are certain variances that we see by state. We can see here the state level per capita greenhouse gas emissions, and this is in 2014. And you can see that generally the Midwestern and Northeastern states have higher per capita emissions than the Western or the Southern states. Washington, D.C. had the highest per capita healthcare emissions in the US, and it has by far the highest per capita healthcare expenditures. This table looks at healthcare emissions, and it looks by country. So we have the healthcare emissions in the first side of the table, and then total country emissions on the right. And so the United States is ranked as number 1 for healthcare emissions and number 2 for total country emissions. And China flip-flops with us in those areas. Let's look globally. So this is globally by region, and Africa is not represented here, but we have 5 regions represented. North America has the highest emissions per capita, and percent global, 29%. Then East Asia Pacific, here in the hot pink, has about 30% global emissions. The lowest per capita is South Asia. So we mentioned scope 1, 2, and 3 before. This gives a better breakdown of what we're talking about when we look at scope 1, scope 2, and scope 3. So for our healthcare emissions, scope 3 is about 80% of our emissions. So we see in scope 1, direct emissions from facilities, anesthetics, and fleet and lease vehicles. Scope 2 are indirect emissions, and scope 3 also indirect, but a lot of supply chain here in scope 3. Again, this breaks down scope 1, 2, and 3, but particularly looking at scope 3, which you can see is just a bit more than 80% of the total. As we see several categories here: water and waste, energy, transport, construction, supplies, medical devices, plastics, rubbers, textiles, and paper. So we all took this pledge, the Hippocratic Oath, to do no harm. And while we do a lot of excellent work as physicians and healthcare workers, we certainly are contributing to harm when we look at climate change. And so this study shows that in 2018, our US greenhouse gas emissions was estimated to result in the loss of almost 400,000 disability-adjusted life years in that year. And then the indirect health damages from healthcare greenhouse gas and pollutant emissions is actually similar to the health harms we see from medical errors. So what can we do about this? This is information coming from Practice Green Health, which is certainly an excellent resource for health systems that are looking to decrease their greenhouse gas emissions. And so for scope 1 and scope 2, we certainly can do many things: renewable energy investments, reducing our inhaled anesthetic emissions, metered dose inhalers reduction, looking at how we construct our buildings and improving our energy management systems. And then for scope 3, there are a myriad of things that we can do in scope 3 to decrease that impact, looking at plant-based alternatives, decreasing our food waste, looking at pharmaceuticals and decarbonization of manufacturing, looking at our medical supplies and medical devices, moving away from single-use or disposable devices and moving to more reusable devices, looking at how we, what we do with our waste and being more energy efficient and water use efficient. Many, many things, looking at electrification of our transportation, etc. So here is an example of decarbonization. This is the only nationally mandated health system carbon accounting in the world, and that's in England with the National Health Service. And they have looked at how they can achieve net zero by 2050. And this slide demonstrates that. So if they did nothing, they would follow this top line here. But if they were to implement their initiatives, they could achieve net zero by 2050. And they're doing that by national electricity decarbonization, looking at new care models and preventative medicine, aggressively decreasing anesthetics and inhalers, improving travel and transport and energy use, looking at their supply chain, etc. There are some examples in the United States. Certainly, Gunderson is the first U.S. health system to attain energy independence, and they did that in 2014. They had a $2 million investment in 2008 and 2009, and they had a 60% return on that. Then also Kaiser Permanente. Kaiser Permanente is certified carbon neutral, and they aim to have a healing effect on the environment by becoming carbon net positive by 2025. In our own hospital, we can look for sustainable solutions. We can advocate for reusable equipment. We can advocate for the decreased use of nitrous oxide and halogenated equipment. Look at our heating, our HVAC systems. Look at more occupancy-based ventilation. I know that in my operating room, it's running whether I have a patient in the room or not. So what can we do to decrease our energy use? The New York Presbyterian Hospital achieved $2 million in annual savings by installing LED lighting, variable frequency drives, looking at their air handler units, their boiler economizers, etc. So there are certainly lots that we can do in our own hospital systems. The healthcare system had quite a response. And the Medical Society Consortium on Climate Change has 48 medical societies that have joined, and they mobilize and amplify the voices of US doctors to advocate for equitable climate solutions to protect and promote health. We also have Practice Green Health, has 1,400 US health facilities, and it's a membership and networking organization for sustainable healthcare and delivering environmental solutions to hospitals and health systems. The Healthcare Climate Council has 21 health systems, which are members of this council. These health systems represent over 600 hospitals and 10,000 health centers in 43 states, with 1.3 million employees and serving over 81 million patients annually. And then the race to zero. So many leading health systems have made commitments to achieve carbon neutrality and achieve net zero emissions. And they've joined this race to zero to achieve this net zero emissions by the year 2050. Some of the hospitals that are part of this are Ascension, Common Spirit, the UC Health Medical Campuses, and the University of Vermont Medical Center. On the heels of this, the National Academy of Medicine mobilized in May of 2021 with a private-public partnership with many of the leaders in the health sector to look at decarbonizing the US health sector. There are several working groups that I have listed here: the healthcare supply chain and infrastructure, healthcare delivery, health professional education and communication, policy, financing, and metrics. They have an overarching steering committee that has on that committee the Joint Commission, CMS, HHS, the American Medical Association, the American Hospital Association, and the AAMC. There have also been federal actions. And so last spring, the White House HHS Health Sector Climate Pledge was launched. It's a voluntary commitment to reduce emissions and improve climate resilience. There have been more than 100 health organizations who have signed this climate change, and they represent together 837 hospitals. So what is the climate change? One, that we will reduce the organization's emissions by 50% by 2030 and achieve net zero by 2015. In order to do this, we designate an executive lead for that organization to oversee environmental sustainability, and that lead should be in place this year. The organization must also commit to developing climate resilience plans for the facilities and the communities, and do an inventory of its supply chain emissions, which is due by next year. And then annually, the organization is going to report its progress publicly. One of the first executive orders of the Biden presidency was the creation of the Office of Climate Change and Health Equity, which is a hub for climate change and health policy, programming, and analysis in pursuit of environmental justice and equitable health outcomes. Following that, in November of 2021, the administration committed to decarbonizing the US healthcare system through the COP26 health program. And then last September, the HHS Agency for Healthcare Research and Quality released its primer on measures and actions for healthcare organizations to mitigate climate change. And that's to support the healthcare organizations in their decarbonization commitments. And so it addresses emissions in 6 ways: building energy, transportation, anesthetic gas, pharmaceuticals and chemicals, medical devices and supplies, and food. The Joint Commission has also joined this effort to decarbonize and to improve environmental sustainability. And so the 3 strategic priorities of the Joint Commission are health equity, environmental sustainability, and workforce. And so with environmental sustainability being one of their strategic priorities, they are proposing requirements related to environmental sustainability for hospital accreditation programs. So that announcement is expected to come out this summer with an implementation in 2024. We do not know yet if these are going to be mandatory or if there are going to be penalties associated with this, but this is the move from the Joint Commission. And then there have been many organizations who have pledged for climate change, and I've listed some of them here, but this is just a few of them. The American College of Physicians, the American Academy of Pediatrics, the National Medical Association has had several resolutions backing their commitment to climate change. The American Academy of Dermatology, the American Medical Association, the American College of Emergency Physicians, the American Academy of Ophthalmology, and Cataract and Retinal Surgery. So what can we do? We certainly need to get involved. So we need to speak about it and we need to take action. And there are many ways to do that. There are sustainability committees that can be put in place in your hospitals. Practice Green Health can be used as a resource to help those committees move their initiatives forward. There are climate clinician groups, such as I have listed here. There are state groups, there are society groups. There's the Medical Society Consortium, Surgeons for a Sustainable Future, and others. And we need to advocate. We need to advocate for our patients, advocate at the government level, etc. And so with that, I look forward to the questions later and Dr. Tummala's presentation, but thank you for the opportunity.
So thank you so much, Dr. Johnson. That was a very interesting overview and exciting news about the Joint Commission and their commitment to hospital sustainability. So we look forward to their announcement. Next, we will hear from Dr. Neelu Tummala with more specific information about the contribution of surgery and anesthesia to greenhouse gas emissions. Dr. Tummala?
All right, thank you, Dr. Mitchell. Can everyone hear me?
Yes, we can hear you and it looks great.
Perfect, great. Thank you so much for having me. I'm really excited to talk to this group today and to join Dr. Johnson in sharing sort of our experiences. And obviously, it's always really great to have a network of clinicians who are interested in this topic. So, without further ado, I have no financial relationships to disclose. So Dr. Johnson talked some about what does climate change mean for health, meaning why is it that we're here today spending this hour talking about climate change, talking about health sector decarbonization. And I'm sure most of us have seen this schematic from the CDC. That's a little bit of a busy slide, but it really shows how the four main climate variables, rising temperatures, more extreme weather, rising sea levels, and increased CO2 levels, cause a myriad of health impacts, which Dr. Johnson had alluded to. And so that is what brings us all here today. Renee Salas, an ER physician, has this great quote where, climate change, our patients are the face of the climate crisis. And that's really what we're seeing in emergency departments, in our clinics, in the hospital systems. It's patients showing up with heat exhaustion, heat stroke. It's patients showing up with worsening pollen allergies. This is something I'm seeing a ton of in my clinic. It's patients being impacted by extreme weather events. And so it's in an effort to reduce these health-related impacts of climate change that brings us all here today, talking about what is our role as clinicians in terms of health sector decarbonization. So there's two main points I want to touch on today. The first is specifically healthcare sector related emissions. And then the second is to build on what Dr. Johnson said, what is our individual role to address climate change and air pollution, and how do we focus that on frontline communities and more vulnerable populations? So again, we saw a little bit of this macro view in this in the last PowerPoint, but the healthcare contributions to climate change are cited anywhere from 7 to 11% of U.S. greenhouse gas emissions. And considering the U.S. is the second largest emitter of greenhouse gases globally, if you're considering 7 to 11% of that, that's a huge contribution from the healthcare sector. Now, we know that some of these emissions are necessary for patient care, but the question is, are all of these emissions necessary, and what can we do to reduce our carbon footprint as healthcare providers? And so there was a really great piece, if you haven't seen this yet, that was in Health Affairs that showed that the U.S. healthcare greenhouse gas emissions rose 6% from 2010 to 2018. And so this, is an unfortunate reminder that our carbon footprint is growing as a healthcare sector, or it did from 2010 to 2018. And so the question is, do we need to have all these emissions, or are there ways to reduce waste and decrease our contribution? So as we heard, there are three ways that emissions are divided: Scope 1, Scope 2, and Scope 3. And so Scope 1 are considered the direct emissions. Scope 2 are indirect emissions usually from energy sources such as purchased electricity and purchased steam. And then Scope 3 is basically indirect emissions from all other sources. I'm not going to go into a ton of detail here just because we heard about this, but I really want to focus on the micro level of what we as individuals can do about Scope 1, Scope 2, Scope 3 emissions and our carbon footprint. So when I think about sustainability in the hospital and the operating room, I think about it in four main categories. And there's a lot of different ways to compartmentalize this. This is just sort of the way that I think about healthcare sector waste and associated emissions. So energy utilization, waste management, waste production, and water utilization are four of the main areas that I'm thinking about. And I included just this one graphic from this study that was published in the Lancet, not specifically to talk about the study itself, although this is one of the most important groundbreaking studies that has really been done looking at operating room emissions, but to really show how different locations in different hospital systems, emissions vary widely. So what works for one hospital system may not be what another hospital system needs or what works for them. And so it's really important when we're thinking about how to address the healthcare sectors that you look at each hospital system on an individual level. And that's part of why forming a sustainability committee or council and really, being able to do an assessment of the hospital system itself is so important to figuring out how can we address specific emissions at that hospital system. And so just looking at A, B, and C, so these are three different healthcare systems. One is in Canada, one is in the US, and one is in England. And then just looking at how much of a contribution anesthetic gases have. So 63%, 51%, 4%. So there's pretty wide variations in these three specific hospital systems and the footprint of anesthetic gases to that hospital system. And so again, as we move forward and talk about some of the things that have worked in different healthcare systems, it's really important to remember every system's a little bit different and that the resources that we have are more of a blueprint. And so it's really just trying to figure out what can we each do as individual providers within our own healthcare system. So energy utilization. So this is a graphic from Practice Green Health, which Dr. Johnson had mentioned as one of the main organizations that really does a lot with sustainability in the healthcare system. So this graphic specifically is talking about OR energy utilization and how to decrease emissions in the operating room. And so there are a lot of different ways to decrease energy utilization in the operating room, such as HVAC setbacks, switching to LED surgical lighting, and one of them is medical device reprocessing. So this is a study out of UAB that looked at slimming down thoracic surgical trays. And so they called this the process of lean. And what they did basically was they took all of their thoracic surgical trays, they got everyone on the team together, and then took out all the instruments that were not being utilized regularly. And so they were basically making their surgical trays more lean based on the most used instruments. And what they found was that, first off, the weight of the trays was reduced. The amount of energy that was utilized to process these trays was, of course, reduced because there was less instrumentation. Operative time was also reduced because the nurses didn't have to look through as many instruments to find the ones that were necessary for the surgeon. And there was incredible cost savings from that 1 year period. Almost $70,000 was saved from being able to decrease the energy utilization of these surgical trays. And so this is just one example of what we as individuals can do within our own hospital system and working together as a team to try to say, okay, what, in this specific case, what medical devices or tools are not necessary, and what can we take away that don't have to be processed all the time and therefore contributing to more energy waste. Waste management. This is a really important one. Yesterday, when I was in the operating room, I was looking at our regulated medical waste bin, and there was stuff in there that didn't need to be in there. And I was talking to one of the nurses about it. And, he was just actually saying they had just had an in-service on it. So they're trying to be better about what is or is not being put into this regulated medical waste bin. And so there's definitely, a growing, I think, movement for a lot of hospital systems to decrease the amount of regulated medical waste. A large part of this is cost driven. It's a lot more expensive to dispose of regulated medical waste than non-regulated medical waste. But there's also a huge emissions component to this as well. The challenge with regulated medical waste is that it varies by state what is or is not considered regulated medical waste. But I think one of the most important things within our own hospital systems It's educating each other, it's educating our nursing staff on educating our physicians, educating students on what is or is not considered regulated medical waste. And some of the ways to try to decrease the amount of waste that's put in a regulated medical waste bin that does not need to be there is to use separate color-coded and labeled regulated medical waste collection containers, post signs at the regulated medical waste collection containers saying what should or should not be disposed of in that particular bin. Make sure that there are enough regular waste bins that other trash can be thrown into, so that regulated medical waste bins are not the default. And then, of course, education and training each other so that we all know why it's so important to only put actually regulated medical waste into those bins, which is a much more energy intensive and higher cost process to dispose of that waste. And I apologize if you hear any sirens. I live near Howard Hospital, so sometimes there will be an ambulance that goes by. So waste production, this is another really important area that we as clinicians can really get involved with in terms of decreasing the hospital's impact. So as an ear, nose, and throat physician, of course, I'm going to pick a tonsillectomy study, but this was a really great one that was put out in 2019 that looked at 3 different techniques for tonsillectomies. And so I used this study specifically to say, or to demonstrate that there's no one right way to do something. And so what this study was showing was that 3 different approaches to doing a tonsillectomy. What is the energy utilization of each of these approaches, and what is the associated waste of each of these approaches? And are there ways to have the same outcome, but have less waste and use less energy in getting there? The one thing I do want to be cautious of saying is that just because one type of procedure or method of doing something is less wasteful does not always mean that that's the right way to do it. Our number one priority, I think all of us on this Zoom call will agree, is patient safety and making sure we're using the right technique for that patient. That being said, if you have 2 things that are otherwise equal and you know that one produces more waste or is more expensive, then is there a role for using the less wasteful process? And I would say, yes, there is. And it's not just to save money, but it's also really to decrease our associated carbon footprint as a healthcare sector. And anesthetic gases. So again, this was something that Dr. Johnson had touched on. This is something that I think has gotten a ton of really important press on over the past couple of years. And I think a part is because anesthesiologists have done an incredible job of raising awareness on this. At my own hospital system, they had a grand rounds on this a couple of years ago. And since then, just being aware of the really high carbon footprint of desflurane, they have really reduced the amount that they use that and mostly use SIVO over DES. And so what this study is showing, and this was produced through the American College of Surgeons, was looking at the impact of different anesthetic gases. So you can see over here, sevoflurane, desflurane, and then using each of those, which nitrous dioxide, and then propofol itself, just using an IV infusion. And what is the associated carbon footprint of each of these anesthesias? And so desflurane has nearly 20 times the global warming impact of sevoflurane. And I think one of the most common things I've said about desflurane is like 1 hour of desflurane use is the equivalent of driving a car 230 miles. So a pretty high carbon footprint there. And nitrous oxide is also commonly used during max induction, has a lifetime global warming potential that is 298 times that of carbon dioxide. So it's really being conscientious of the carbon footprint of both of these, the global warming impact of both of these anesthetic gases, and trying to say, do we really need to be using these or not? Or are there potential alternate equivalents that could be used for patient care? And then, of course, we can't talk about any of these sustainability things without talking about something that really matters to hospital leadership, which is, the economic benefits of sustainability. So, when we think about each of these, research projects or different areas of sustainability that we're able to really gain momentum in and decrease waste and reduce carbon emissions, a lot of times these initiatives are initially looked at as ways that the hospital has to invest more money in. But actually, if you look at a lot of the literature, and Healthcare Without Harm and Practice Green Health are both great resources for finding out some of these numbers, there's actually pretty impactful long-term economic savings with a lot of these sustainability initiatives. And so thinking about the second goal, what is our role of addressing the health risks of climate change and air pollution? I don't know if this. All right, I don't think my video is going to work, but basically this was a video that one of the state-based advocacy organizations that I'm a part of, Virginia Clinicians for Climate Action, put out last year. It's on our VCCA website, but really it's a bunch of different clinicians talking about why is it that climate change and air pollution are important to us, and why is it so important to the health of our patients. So where to begin? This is all of us, a bunch of us from Virginia Clinicians for Climate Action. We went down to Richmond in February to advocate with Virginia state delegates on the importance of Virginia climate solutions and energy policies. And so when I think about my personal role as a clinician, I think that there's three different areas that we can approach this as. So research, advocacy, and education. So research forms the basis of so much of our work, right? So when I was talking about each of these sustainability initiatives, I used a research study to demonstrate what is the impact of this work. And when we're talking about the health impacts of climate change, research forms so many of the things we say. So we're able to say that pollen allergies are about 3 weeks longer now than they were 30 years ago because of the research that's been done. We're able to show in this Science Advances study that communities of color are exposed to higher levels of air pollution from every single source in the United States based off of this research. And then this last study shows the connection between air pollution and chronic sinusitis. And so I think there's a lot of different areas of research that each of us can get involved with. And a part of this is just figuring out what is it that interests you, and where is it that you want to see a greater understanding of the impacts of climate change and air pollution on community and population health. So thinking about advocacy. So a couple of these organizations were already mentioned by Dr. Johnson, but if you're not on the email listserv for each and every one of these, I would definitely recommend it. I learned a ton just from perusing through each of these emails, and they're all really great organizations that are doing a lot of important work on the intersection of climate justice and health. The way that I think about advocacy is 4 different areas. So the first is education. So this is both educating ourselves as clinicians and then also educating the community that we're a part of. And so educating ourselves could be anything. I mean, we're all attending this webinar right now. And so that's, really important for forming our own basis, our own knowledge level. And then we could take this information and talk about it with our colleagues, talk about it with our family members, with our community. And so really the education of ourselves and others is vital to the work that we do as climate advocates. Creating a network. This, I think, has been one of the most impactful things that has helped me as an individual clinician have a greater impact. And so, as I mentioned, one of the state-based organizations I'm a part of is Virginia Clinicians for Climate Action. And a lot of different states have these state-based organizations. And then also within my own university, we formed the GW Climate and Health Institute. So that's helped me from an institution level to really be able to make more of an impact. And at GW, just a couple of weeks ago, we actually got climate change approved by the medical school curriculum committee to be incorporated longitudinally over 4 years into the medical school curriculum. And, I think unless we had had a team-based approach with students and other and other colleagues to really address this and push for it, I'm not sure that that would have happened. As Dr. Johnson mentioned, advocating on every level. And so really doing whatever we can within our own communities, within our local government, state governments, and then different community-based organizations. Every single one of these areas of advocating has a different impact, and you're reaching a different population. And as healthcare providers, every avenue we can use to disseminate this information is going to be helpful with protecting health. And then last, be experimental. So this is some of my favorite advice that I got from Dr. Lazarus of the Yale Program on Climate Change Communication. When I was first starting out, I really wanted to be told, what is it that I can do as a clinician? And honestly, there's no right path forward. It's just trying to figure out how is it that you can connect with your hospital system, with leadership, with your patients, with your community, to be able to be an advocate for hospital sustainability solutions, thinking about climate justice work, disseminating this information on how people can protect themselves from extreme weather events, from heat. And so there's no right or wrong way to move forward. It's, we're all in this together, and we're all just trying to make whatever impact we can. And so this is one example of advocacy. So this was some emails that I actually got a couple of weeks ago when the EPA was taking open comments about making their air quality standards more strict. And so this is just one way to be a public health advocate, is to submit public comments. As we mentioned earlier, any sort of conversations you could have with your patients, your family, your colleagues, reaching out to elected officials. This is us meeting. I'm with a VCU medical student there, as meeting with a Virginia State delegate about Virginia climate policy, and then joining whatever local, state, and national groups that you're able to. And then finally, education. And so I know we're running out of time here, so I'm just going to spend another 2 minutes and then I'll be done. But really, I think students are leading the change, especially in medical education curriculums, of getting climate change incorporated into those curriculums, which is really important for the future of medicine and making sure that future providers know how to treat their patients. Educating our colleagues and educating leadership. So talking about what are scope 1, scope 2, scope 3 emissions? How can we be less wasteful? What are areas of change that we can have within our own hospital system? And again, I think it's worth spending some time on the Practice Green Health and Healthcare Without Harm websites to understand the economic benefits and ways to approach these conversations. And then, of course, educating your patients, as clinicians and scientists, and nurses, we're some of the most trusted voices in the community. Nurses are number one. And so really, being a voice for change in whatever way we can. And Dr. Johnson already went over this healthcare pledge. But the reason I wanted to keep this slide in here is to say that a lot of this work is boots on the ground work, meaning that we as individuals can approach our hospital leadership. So I actually just got an email from Amy Collins, who I think is on this call, as a reminder to say, talk to your hospital leadership. And so I actually reached out to my hospital leadership. It was sort of a reminder to me to schedule an appointment to talk about this. And so we're meeting next week. And I'm not sure what will happen, but again, it's really just having that conversation, being that voice for change, and making sure that, we're all, the more we talk about it, the more change we're able to do. So thank you.
So yeah, thank you, Dr. Tummala. So we certainly appreciate the information and on how we can move forward and take step-by-step actions to green our healthcare institutions. Now we will take questions from the audience. I remind you that you can type your questions into the chat box, and we'll get to as many of them as we can. We ask that you please take a moment to fill out the webinar survey. The link to the survey is also in the chat. And today we're talking about hospital systems, but also wanted to remind you that there are toolkits for greening clinics and physicians' offices under with mygreendoctor.org. You can look there to find tools for that. But let's go ahead with questions. So Jordan, what questions do we have?
Sure. Thank you both for the presentation. Shaneeta, this first question is for you. Is the northern U.S. higher per capita due to the heating costs, or do we know why they are higher in the north?
So that state level per capita greenhouse gas emissions is from personal healthcare expenditures. And so the authors of this study feel that the reason that it's higher in the Northeast is from higher healthcare expenditures per capita in the Northeast.
Thank you.
Then, thank you, Shaneeta. And a quick follow-up on that, I think it related to a slide or two later, was just about if you knew what percentage of hospitals the data represented.
Which slide?
No, I'm sorry. I was actually asking you provided a number of hospitals that are participating in the pledge. And I was curious, I don't know how many hospitals there are in the US. So I don't know if that's a small percentage or a large percentage.
It's a significant percentage, 837 hospitals. It's a significant percentage. I don't know exactly what that number is, but that's a good question. I'll look for that.
Thank you.
Actually, Dr. Collins has put into the chat that it's 12% of hospital. Jordan, are there other?
Yeah, I'll move to some others. I know, Amy, thank you. You've been very, very active in the chat answering some of the questions. Neelu, I'll bring this one to you. Have you looked at capturing waste anesthetic gas within the OR to reduce emissions?
I have not personally. I don't know that there is a study that. So is the question specifically, not allowing the anesthetic gases to be released into the environment, but to actually capture them?
I think so. And Dan, feel free to comment in the chat if that's right. But I think we can move with that assumption.
Interestingly, I was actually at a talk yesterday about with anesthesiologists, and one of them was saying that he knows a clinician in Texas who has come up or patented the technology to be able to reuse anesthetic gases from like one patient to another. But apparently there's, just that idea, I think, of what one person has breathed it in, having someone else breathe that in, even though there's not really any sort of negative health concerns with that. Or at least this is what I was told, that it just has not been a very popular technology, just sort of that idea of reusing anesthetic gases. And so I don't know exactly where that conversation is going, but it was an interesting technology that I didn't know existed, that the anesthetic gases themselves could be reused.
So if I may, we had one of our fellows to look at that last year. And in fact, there are a number, there's some research studies that do that both capture the anesthetic gases instead of releasing them directly into the atmosphere. And then there are other studies on how to reuse anesthetic gases, but the mechanism, the regulatory mechanism has not been put in place. It has not been commercialized. I think that, that these are some of the kinds of things where we need more research and advocacy to move forward on that. With that, I know that there are a number of other questions from the audience. However, we need to wrap up this session. So I'd like to thank our speakers and thank all of you for participating in this webinar series. I hope that you found it useful. And as a reminder, this webinar series is hosted by the Medical Society Consortium on climate and health. They're held on the second Friday of the month. The next webinar is scheduled for May 12th, and the topic is extreme heat. Before we leave, we ask that you take a moment to complete the webinar survey if you haven't already. Again, the link to the survey is in the chat. And if we can pull up on the screen our PowerPoint, the slide and that we announced earlier at the start of the webinar, that we're pleased to offer continuing medical education credit for our webinars this year. To earn CME credit, please follow the link in the chat or scan the QR code on the screen. And we will post later follow-up directions on our website if you're not able to follow get the instructions right now. So that now concludes our session. Thank you all and have a great day.
Okay. Is that it?
So yes, that's it. So the fellows can head